Welcome, everyone. It's great to see you this morning in rainy Atlanta. And this is a session to review with you current procedural terminology, CPT, from the perspective of health IT developers. And we're really delighted on behalf of the American Medical Association to be able to share with you some information about CPT as one of the vocabulary terminology code sets that's important within HL7's work, and also to share with you our various activities underway with HL7 and the collaborations activities that we're doing. I do need to ask that you take a look at this slide, which enumerates AMA's disclaimer notices about the content and recording and things like that. The slides should be available after the session, so if you don't have a chance to digest everything on the slide at this time, you certainly will have the opportunity to review it more closely. This slide is an effort to introduce you to the speakers this morning. Myself, Leslie, and Dennis will be walking through a fairly comprehensive agenda, and we're hoping to cover as much as possible during the session. And please feel free to directly pose questions that may come to mind, or certainly send them through the HL7 app. This is what we hope to cover. I'm doing the introductions, the basic overview. I'm going to highlight HL7 and AMA collaborations. We're thrilled that Dan Vreeman from HL7 is with us this morning, and Dan will also offer a few remarks about the work we're doing together. Leslie will walk us through CPT as a terminology, the code set and structure. Dennis will talk more about the standard file that is made available to HL7 and other licensees. And then we'll talk about the AMA Developer Program, which is available, and we're not so sure very many of you are aware of what is available to you as an early entrepreneur developer. And then we'll also provide you some links to additional resources. Several of them are freely available on the AMA website. So to just begin the conversation, AMA has a long history working with HL7. AMA has been an active benefactor member of HL7. I actually don't remember for how many years, but it's been many, and is actively involved in several work groups. These are noted on the slide. Several members of our staff are here in the audience who have participated a lot in things like the Gravity Project, the Da Vinci Project, Orders and Observations, ACL, Administration for Community Living, and even more recently, we've started to follow the EHR work group and AI in particular because of emphasis on physician burden and other workflow issues that are being brought to the fore. We actively participate as much as possible in some of the balloting and review of draft and to be normative work products that the HL7 community develops and shares. Happy to talk more about that, again, as part of, for example, Gravity, Da Vinci, and also our leadership work that we do with the HL7 Financial Management Work Group, where one of our staff, Celine, is one of the co-leads of the Financial Management Work Group, which also intersects with patient-provider, provider-payer, data flow, clinical data exchange, administrative data exchange. So we're really happy to have had this history, a long-standing history of working with HL7 as a member. And I want to mention that about a year or so ago, it was in April of 2023, that the AMA and HL7 finalized some more official collaborative agreements. And that builds on all the years of collaboration and cooperation and activity that AMA had as a member. And we signed two agreements between AMA and HL7. One is the CPT is a CPT license agreement. It is a royalty-free pre-production license agreement that gives HL7 and members who are working on HL7 products, which are HL7 implementation guides, HL7 value sets, and the HL7 terminology services, to use CPT in the development, testing, and rollout of those products. And we also expanded some of the collaboration. And as an example, I'll show you in a few minutes, we are working with HL7 to refine, update, and clarify some of the information about CPT that is displayed publicly on HL7 web pages. Dan, I'd be happy to have you offer some of your perspective on the work that we've been doing together.
Thank you so much. It's a real pleasure to be with you today. My name is Dan Vreeman. I'm HL7's Chief Standards Development Officer. As was mentioned, AMA and HL7 have been collaborating for more than a decade, I'll say. It's been a long time. And that contribution is with the shared vision of advancing interoperability. And both organizations have complementary strengths, and it's been a real pleasure to press forward with some expanded opportunities under this collaboration agreement. Both organizations have appointed liaisons, so we have formal communication points back and forth, a way to share information, and identified key connection areas, whether those are industry events or educational sessions like this one, where we can really benefit from the offerings and opportunities that each organization has. In particular, we're especially excited about opportunities to enhance the use of CPT within HL7 standards, and especially FHIR. One of the sort of fundamental advances that FHIR makes is really in its terminology representation, and that formalism really provides a mechanism that can advance semantic interoperability for many, many different use cases. And so one of the key aspects of this collaboration, as was mentioned, was really a landmark licensing agreement to make it possible for HL7's standards development activities to make use of and represent CPT content within those implementation guides across uses, and to be able to effectively use that content in testing events in a non-production, non-commercial sense. And to that end, opportunities to sort of build that into our testing infrastructure has been a great advance. So from my perspective, this is a wonderful collaboration, and we're looking forward to the many opportunities ahead. Thank you so much.
Thank you so much, Dan. I would like to reemphasize the vision that both organizations have, and how we're very excited to help advance not just the use of CPT, but also one of the reasons for this session is to provide some high level and then do a little bit of a deep dive without getting down too many rabbit holes about the nuances and structure and content about CPT as a system to be utilized and utilized within FHIR, with an expectation and a hope that this information will help you better understand how you might be able to better utilize CPT in those standards development activities. This slide is, I'm sorry, a little hard to read from afar, but as I mentioned, one of the other activities that we are actively engaged in is working closely with HL7 members, participants, and staff to to review a prioritized list of HL7 content on the website. And we are in the process of focusing on these the first three. One is using CPT with FHIR. The other page is Code System Current Procedural Terminology, which is a more in-depth page that goes into various aspects of the structure and content of CPT, particularly those aspects that might impact how to embed a CPT code within a fire standard. And then there's a long list on one of the pages that's called external code systems, where CPT is one of many code systems where HL7 identifies those terminologies and vocabularies that are used within fire. So the first three are our priorities, and then this slide notes that there are many, many other public-facing pages that we are in the process of planning to review. For example, there are many value sets that call upon CPT, and we are also going to look at those in time. They'll be put through a process of review and approval, and then updating on the website in accordance with HL7 processes. So I did want you to stay tuned for that. In the meantime, if you are reading these pages and have questions or suggestions on how to make things make more sense more easily, please feel free to reach out to us. We'll have a email address at the end of the slide for you to contact us for any questions or thoughts, but we welcome your feedback as you utilize CPT information. To sort of start to segue into the focus on the CPT content, this slide is an effort to demonstrate and depict for you how CPT content is used. Some of you may associate CPT as a means for physicians and other qualified health professionals to encode services, treatments that have been rendered by these clinicians and practitioners to patients, and those get included on bills. They get used for prior authorization and other medical necessity functions. But CPT actually is also very much utilized to help assess quality of care. It is certainly used to do evaluations and risk return on investment kinds of analyses and research related to cost and access to care. And if you would like a deeper dive on some of the ways that CPT is embedded, for example, in Medicare and Medicaid payment models, value-based care, and other things, we'd be happy to share that with you in case you are looking at use cases beyond just billing and reporting for billing purposes. This slide, I don't need to read it to you, identifies other use cases that CPT is used for, and certainly one of the main reasons we're here today is to focus on interoperability and standards development. One of the themes you'll see as we continue our session today is how vital it is for CPT to remain innovative and in the forefront of being able to represent new technologies, new services, and how to keep pace with emerging health technology trends that impact quality of care and care delivery, but also impact the coding and reporting of procedures and services and treatments. And this is an example of 6 categories that from a coding perspective, and in coding we also mean reporting, and many of the IGs deal with coding and reporting for various use cases, including quality of care. This morning, the general session presentations talked about public health data reporting. We're all collectively keeping an eye on more use cases coming from our friends at various federal agencies, including CMS and the Office of the National Coordinator, now the ASTP, the Assistant Secretary. It also is coming to fruition within other agencies like HRSA regarding federally qualified health centers. So there's a lot of reason for us to want to make sure that the CPT content is very flexible, nimble, and can reflect innovation as well as new clinical and health information technology standards, trends, et cetera. This is a summary for you of the various use cases where CPT is currently being used to reflect, again, every task and service that a medical practitioner provides to a patient, including medical, surgical, and diagnostic services. And CPT applies to all of these use cases. You'll see that HIT developers and implementers, as well as standards developers, are reflected on this on this slide, and certainly we don't want to understate the value for CPT use across other use cases. However, we are trying to broaden your perspective on how CPT is not simply a medical coding nomenclature. And with this, I'm going to turn the podium, the lectern. I've heard that podium and lectern are not synonymous. I don't know where I saw this, probably on LinkedIn or some Facebook page or Instagram. I'm dating myself. For Leslie to share some more refined information about how CPT is structured and what comprises the various components.
Thanks, Meryl, and good morning, everybody. We realize for some of you, we're probably the last presentation between you and lunch or outbound flights, depending on your situation. So we'll keep things going. And just a little bit of introduction. I'm the Director for CPT Content Management and Development at the AMA. And what that means in a nutshell is that the view of the CPT code set from my perspective is I have teams that work to curate all of the information, all of the codes, all the descriptors, all the rules that go into this code set, as well as providing guidance on appropriate use of the codes. And it's a little bit different in the HL7 area, so this is a great expansion, and it actually harkens back to my own personal development as an analyst and a coder back in the day from, I'll talk about SAS, but I'd probably date myself terribly. But I'm going to give you a little bit of an overview of the code set from a perspective, not only from a computer programming perspective, but a little bit about what's behind it, so you get a sense of what this means. And I'm going to talk about this from the perspective of most of your use cases are probably going to be from a secondary use perspective. So you're not generating the codes yourselves, but you're using them in other applications. And so some of the items that we're going to talk about are really going to be about those kind of technical aspects. I will say if you are looking at use cases that involve things like auditing codes, did someone use the proper codes? We won't get into a lot of that today, but there will be additional rules around how the codes are used. That's probably best reserved for a 201 course, but I'll give you the overview of the technical structure today. So when we talk about, I'm going to talk a little bit about what is CPT content, a little bit of the history, not much, but the fact that some of the history impacts the way the codes are structured and what you will see. So I want to make sure you understand the connections there. We'll talk about the structure and components, some of the different code categories, formats that you will see as you start using this data. We'll go a little bit into descriptions. Just remember one thing, words matter when it comes to CPT and the descriptors, and I'll get into why in a minute. We'll also talk a little bit about modifiers, which is an additional construct that's used in CPT, and then I'll spend just a few minutes about how these codes are created, how are they maintained, and how do we update them, which is very important for all of you to make sure that you keep current with your algorithms and the programming that you're doing. So if we want to talk a little bit about what CPT is, this is probably the quickest synopsis I can give you. It is a uniform language of descriptive terms and identifying codes, and it's designed to describe medical, surgical, and diagnostic services, and it's used for nationwide communication among a number of different constituencies. So it's not just physicians and other qualified healthcare professionals, but also patients and third parties. Now, the third party part is important because when you take a look at the structure of some of the CPT codes and what's here and why we've got them grouped in certain ways, the fact that we are interacting primarily, this is used in, among other things, as a structure with payers and reimbursement. There's a lot of interactions with those systems that have an influence on how some of the structure works. So we'll talk about that. In terms of the history of the codes, just realize that the code set has been around since 1966. It's still here. It was originally a code that was designed for surgical procedures and a few medical procedures, but over the time it has expanded into other areas. what I would really like to make, and by the way, I believe these slides will be made available, so don't worry about having to take a picture or trying to scribble everything down. But basically, over 50 plus years of CPT evolution, you will see a lot of milestones that are driven by a couple of things. So certain events that serve as catalysts for adoption. Some of them are expansion of services that have been provided by physicians, designation of CPT as a HIPAA standard, a HIPAA code set standard, that was a big one, as well as some of the other legislative areas around things like protecting access to Medicare, molecular pathology code sets, or high-tech, and some of the other interoperability standards. Each one of those has had an influence on some of the subsets of CPT. So when you take a look at this, it's primarily to record the work of the physician. And this set, by the way, remember, when you think about it, this is a set that was designed by physicians for physicians to use. So it was not designed as a native digital set. It has evolved over time. It continues to evolve. But realize that some of the influences and regulations have impacts on some of the codes and some of the code structures that we've made. So we'll go into a few of these, but just to say it continues to evolve, certainly not done by any means. And the latest ones we're really getting into are areas around digital medicine, telemedicine. So simply providing service, how it's done is almost as important as what you do. So the code set accounts for both of those. A little bit on HIPAA and CPT. And if you're familiar, probably already familiar with HIPAA, but one thing to note is that the CPT codes and the descriptors and modifiers and HCPCS are named as the procedure code set for certain categories of activities. And what this means is when it comes to, when I said words matter, this is where those words matter, because those official descriptors are sort of locked in for HIPAA use. So depending on how you're utilizing value sets and utilizing and creating your applications and interactions, just realize that when it comes to those kind of official descriptors, those are things you probably don't want to alter in any way when you're looking at items. Now, there have been additional HIPAA descriptors and designations that have been made. You're probably familiar with most of these. So ICD-10-CM is the standard for diagnosis codes, PCS for inpatient hospital services, CDT, and we talked a lot about the interoperability with CDT. It sounds like there's been a lot of work there, which is great for dental services, and NDC for drugs. But when it comes to CPT, it's physician services, physical and occupational therapy, radiological procedures, clin lab tests, all the items that you see here with CPT and HCPCS. One note on HCPCS, and I don't know how many folks are familiar with all of the different billing systems, but I will want to make one slide about the use of HCPCS. So when you hear that term, Healthcare Common Procedure Coding System, there's HCPCS and there's HCPCS, in quotes, okay? And we feel your confusion. We didn't create it, but as you start going through and using these code sets, you will see that acronym used in more than one context, and so I wanted to make sure that you understood this. So the Healthcare Common Procedure Coding System here in the US, it's comprised of two different sets of codes. You will hear HCPCS Level 1. Level 1 is CPT, okay? And those are primarily, physician services, the categories that we talk about. You will also hear HCPCS come, and there's also a level 2. Now that set of HCPCS is for services and items that are it's maintained by CMS, and it describes products, supplies, and services that are not produced in the CPT code set. So an example might be things like supplies that are used, particular drugs that are administered, transportation services that a patient will utilize. CPT won't cover those, but the other HCPCS will cover them. You'll find this interaction if you are doing anything involving looking at claims data, anything involving how you're working with billing. I'll give you an example. A patient's receiving chemotherapy infusions. You will have a CPT, a HCPCS Level 1 code to account for the infusion. And you will have a Level 2 code to account for the drug. that's being infused. So as you're going through, you will see these two sets will start to interact with each other, depending on the service that you're working with or the claims information that you're working with. But just realize HCPCS can have a little bit of dual meaning. So just, we didn't create the confusion, but it's there. So just to be aware of it. But if you hear about HCPCS level 1, that is what CPT is. It's just that there's more than one HCPCS out there. Okay. Now, this common procedure, and we talk about level 2 codes in HCPCS system, here's one thing you'll be able to remember when you look at the structure of the codes. So HCPCS level 2, maintained by CMS, their structure, code structure, is pretty much, it's a single alphabetical letter followed by 4 numeric digits. Most of these are 5 alphanumeric, the letters in front for HCPCS level 2. CMS maintains these, including the decisions about additions, deletions, revisions. It's been around since the 1980s, and in 2003, there was a lot of standardization in early 2000s for folks who were around then, and the HHS Secretary delegated authority to establish and maintain uniform national definitions of these codes. And for those that have been around for a little bit, you remember there was a time when there were a lot of local and regional code systems that were used. And a lot of the HIPAA standards kind of cleared a lot of those out. But we've placed the note there in case you're interested in more information about those level 2 codes. We're not going to go into them much today. Just know that they do exist. The structure is a little bit different. And when you start seeing CPT on claims, I almost guarantee you will start to see HCPCS come along with them. So in terms of CPT code set, we're going to talk about a few components today that will be of use for the work that you're doing. So we're going to talk about the CPT code itself. Basically, that is 5 digits. It's alphanumeric. There's a couple of different structures of that alphanumerics that will go along to help you identify the type of code you're working with. We'll talk about the descriptors. Now, this is where I said words matter. So you're going to hear the terms long descriptor. That is the official descriptor for that code. It is also the most comprehensive descriptor for that code. CPT also creates additional versions based on their intended functions. So if you have a descriptor that's designed to be used, say, within an EHR, perhaps you've got certain types of character limits, you can't have that long description, we do make what are called medium descriptors, short descriptors, as well as descriptors that are designed for certain audiences. So we have an official descriptor for our code, but if this is in a patient-facing portal, there is no guarantee that a patient is going to be able to understand the terminology in that descriptor the way a physician would. So we actually create things like consumer descriptors that are designed for use in patient-facing portals at a language level that is appropriate for a general patient population to be able to understand. There are clinician descriptors as well, and we'll get to those. We also have translations in a couple of languages. I believe Spanish was the most recent one that came out. But in some of these, we do have translations that have been done. And then we'll talk a little bit about modifiers. These are 2 digits, alphanumeric, and again, they talk about services that are altered by a particular patient circumstance, but the basic definition of the code has not changed. But it's a way to signify a little something different with this one. So we'll go into that. Now, in your code set construction, what you see on the right-hand side here, it's kind of interesting. We're going to talk about how to best represent this as data. And you might find that this structure is a little unusual because when you actually look at the files that are available in the value sets, it's going to look a little different, obviously. It's going to be a little more of a flat file. But I put this up because for anyone who is working with end users of CPT data, either coders, physicians, billing representatives, practice managers, whoever it is, if you have to interact with your end users, they're probably going to be used to seeing CPT look like this. This is an excerpt from our CPT professional codebook, and it is primarily how many people will see this. There's a couple of, but there are a few elements I want to highlight to you that will probably translate over into the digital files that you'll see. So first, you're going to have your code number. Again, it's either 5 digits, alphanumeric. In this case, this is for a remote monitoring of physiologic parameters. So this is a lot of remote digital medicine here. So you'll have your 5-digit code number. Then you'll have your descriptor. Okay. So, and this is kind of the official descriptor here. So this is for remote monitoring of physiologic parameters. For example, we give examples in this one. And it's the initial setup and patient education on the use of equipment is what the service is designed to provide. Now, there's some educational references as well that will come in here. And I'm not sure, maybe Dennis can talk a little bit about the file structure later on about those resources. Remember, this is in a printed book, so we'll say this is the code, this is a descriptor, but we also always provide additional guidance on how it's used. When something changes, we also provide additional educational resources on that so people understand the reason for the variations. And then there's something called parentheticals. Now, these are particular instructions that are more applicable to people who are using this in a primary use, so they are going through the medical record, determining what is the appropriate code to apply. And in your secondary use, you won't necessarily have to see that, but just know that your initial users, your initial generators, will have additional instructions that they are using to apply those codes. Okay. All right. There's also, you see on the next code, 99454. It's kind of indented in a little bit. And one of the things that I will probably want to note is that when it's indented, what you'll see is that this is really a way of placing this in the book such that it's a little bit of shorthand. But how you would read it is that it's an indentation, it's a truncated descriptor, and the key that you want to keep track of is in the initial code. We've got remote monitoring, physiologic parameters, it says initial, and there's a semicolon. The one thing I will note is never underestimate the power of a semicolon in CPT. You'd be surprised how many people debate over the positioning of that. But what that means is that everything that's before that semicolon, that is a part of the descriptor for that group of codes. So when we're looking at 99454, that first, it's still talking about remote monitoring of physiologic parameters, the initial. The first one is setting up and patient education on the use of the equipment. 454 talks about supplying the device that they're going to be using for their physiologic monitoring with recordings or programmed alert transmission and reporting for every 30 days of use. So if you're looking at these codes, and you'll see these in your data sets as well, when you look at the descriptor, if you see a semicolon, remember everything before it is probably is referring to those and the groups of codes below it. So that indentation is just that shorthand. Okay, it's going to be what's in front of the semicolon in 5.3, and then what's after the semicolon in 4.5.4 put together makes your key distinction. Okay. Okay, let's see. Now let's see if our slide's going to keep working here. All right. So with that, I'm going to go into a little bit of the CPT code structure, and you've got really 3 different categories of codes within CPT. So you've got category 1 codes. These are what we call kind of the gold standard codes, if you will. So these are represent contemporary medical practice, evidence-based, widespread use, and they're broken into 6 different categories that you see here. And the main body, each one of those sections is further divided into subsections, and you'll see that in the data files that are in your value sets, with either anatomical, procedural, condition, or descriptor subheadings. And one thing to explain is the medicine category. People think medicine is pharmaceuticals. It's not just pharmaceuticals in this case. It's a little more of a varied group of procedures that we'll get into. Many of them are diagnostic in nature or not necessarily in a surgical suite. But just remember, when you see medicine here, it doesn't just mean pharmaceuticals and drugs. The second category is category 2. And this was probably more appropriate if anyone was in the session that was just in this room before we were, talking about performance measurement and quality of care codes. So there actually are category 2 codes. We're going to go over those in a little bit. And then we've got category 3, emerging technologies, and then a couple of unique areas in lab and pathology, if your work takes you there, that you'll want to know about the structure of those. Most of the codes are, the main distribution of codes comes out every year. As a matter of fact, Right after Labor Day, we just released the 2025 set, so you want to make sure you keep current. So there's a little over 11,000 codes and change in the code set right now. And we'll go through a little bit of each one of these, a little bit of how they're structured, and to note they're all created for slightly different purposes. So keep that in mind as you start working through your coding. The Category 1 codes, as I indicated, this is the most stringent codes. They meet a very high standard in terms of evidence, validation criteria. The codes, by and large, are ordered sequentially, with one exception in evaluation and management. And these are consistent with contemporary practice, clinically recognized, generally accepted. They are all 5-digit alphanumeric codes. Position 5 is going to be your key distinguisher when you take a look at these codes. So when you're looking at CPT codes, look at the last digit. If it is a 0 through 9, chances are that's going to be a Category 1 code. Okay, that's what you want to pay attention to. Also, if your work is taking you into looking at payer information, reimbursement, valuation, these particular codes go through an additional process once they're approved by the editorial panel to estimate, create an estimate of the amount of work that is required. I won't go into that into detail, that's a whole other presentation. But if you hear something called RVUs, or relative value units, that is an input that is often used in various structures by payers as part of an input to help determine reimbursement rates. These are the codes that go through that process. They will have a particular relative value assigned to them. So that's one thing to kind of keep in mind as you take a look at these codes. Now, the code organization for each one, we won't put them all up on the screen, but I think it's important to remember when you look at how the codes are organized in each of the sections, they are organized based on the intended use. Remember, this is designed to report the activity of a physician. And so what you will find is that not all of these codes are organized quite the same way. When you think of the frame of form follows function, that is what you will see here. So with evaluation and management, codes are organized based on the type of evaluation. Is this an office visit? Is it happening in an emergency room? Is it happening in a nursing home setting? Is it a home environment setting? Anesthesia may be based on the body site and the type of site. So general anesthesia, when you think about it, is a little bit different from a local anesthetic, an epidural block, or where that happens to be happening. Surgery is generally organized by body system. Radiology is basically based on the work performed and the modality. So is it CT? Is it an X-ray? Is it ultrasound? Is it something else? And where is that being performed? So you'll see different structures there. Pathology and laboratory, again, based primarily on the work performed. So a basic chem screen is going to be different from some genetics work and other types. Medicine is based on the work performed, and again, that's quite variable. You will find a number of different services there. Most of them are not occurring in a surgical suite, although that isn't a clear differentiator. But you'll find a number of different areas there, everything from psychiatry, physical therapy, occupational therapy, ophthalmology, cardiology, GI. The list is pretty extensive. So when you're thinking about this from a programming or a hub standpoint, those subcategories will be helpful to you. If you think about, let's say you're creating a subscriber application and you want to look for codes and have it return input related to orthopedics, anywhere in orthopedics. And if you're going through all the different Category 1 codes, there may be different types of terms, and you're relying on that hub to categorize those messages that meet your criteria. It might need to identify things in different ways, depending on where in the CPT and the Category 1 code set you are. So this is just a high-level illustrative example. So if I'm looking at anesthesiology, I might be looking at upper leg. If I'm looking for path and lab, I might be looking for anatomic pathology procedures. Medicine, it could be anything, physical med, rehab, neurology, neuromuscular procedures, nerve studies. Radiology might be lower extremities. So each one of them is expressed a little bit differently within certain areas of the Category 1 subset. So just to keep those in mind as you're creating some of your algorithms for returning information. Now, Category 2 codes are a little bit different. These are the quality measure codes. They are designed for performance measurement improvements, and they are based on evidence-based national areas of focus for improvement. They're a little bit different than the procedure done. And here, if you have a quality improvement background, the goal of these is to say, did a patient get a particular service that might have implications for optimizing quality of care for that patient? So typical example might be what you see here on the left-hand side. So for community-acquired bacterial pneumonia assessment, were the following items done? Now, it doesn't say what was done, but it's like, for the patient that meets certain criteria, did they get everything that they should have gotten to hopefully optimize care in that area? From your standpoint, what you'll want to know with these is that the use of these codes, and this is probably the only area in the code set where Category 2 codes, the use is optional. Okay? A lot of it will be driven by whether or not there's a certain payer, perhaps they're using them for certain quality programs. Many of the state Medicaid programs I know use these to help assess quality. It's designed to give the physician a little bit of easing of that administrative burden where they don't have to go out and code everything in a separate system. They can actually report those codes here. When you see a Category 2 code, you will know because that code will be 5-digit alphanumeric, it will have a letter F as in Frank in the 5th position. That will indicate that this is a Category 2 code. And when you go through and look at some of the descriptors, you know, another good example I used to always have way back in the days when before Core Measures was digital, and there would be measures for heart failure. Or, you know, one of the key ones would be, did the patient receive smoking cessation counseling? Yes or no? That's the type of thing this is designed to get. And there's a number of different algorithms that are placed for these codes. Key things to remember about CPT Category 2 codes. Again, this is the one set where use is optional. So if you are looking and returning information and you're looking at prioritization of codes, this can be very important from a reimbursement standpoint. If you are looking at these, remember, these are optional. Many times they are not determining the payment for a particular procedure or encounter. So in terms of where they fall in the record, where they should fall in the record relative to other codes that are required to be used, keep track of where the prioritization is in terms of the sequence. The other thing is for any statistical calculations, percentages, comparisons across organizations that you may be doing. Remember, of course, use is optional. It may vary depending on the reporting requirements for that particular payer or organization. So I would encourage you to exercise caution if you're trying to compare across organizations, because not everyone has to report everything. And if you have to prioritize in terms of what will come in on that claim, I will tell you, if they don't have to report Category 2s, they might not show up. So be careful with your categorizations. Also, like any other quality measure, this is based on numerators and denominators. So you want to, when you look at these, it's really looking at those numerator measures. It may not give you the entire underlying population. Because when you think about it, this is all based on claims for an individual patient. So if you have a population and they haven't been seeing that physician or they didn't come through, your denominators may be a little off. So just exercise a little bit of caution with optional measures. Some of the subgroups of different quality measures of Category 2 codes are here on the side, but you will see quite a few that will come through, but they are all based on national evidence standards, and just be careful with their use. They can be very helpful, but be careful about cross organization comparisons because it may not be exactly standard. Okay, Category 3 codes. So this is where you want to see innovation represented. It is Category 3. So Category 3 represents one of our fastest growing code categories. These are temporary codes, and I'm going to put some air quotes around temporary. It's kind of like that temporary code that you write and you think, oh, I'll only use it for a couple years. A couple years gets extended. You look 10 years later, it's still there, you know, still being used. But the idea behind Category 3 codes is that this is for emerging technologies and procedures and paradigms, and to make sure that we capture those within CPT. They may not have been around long enough yet to meet the standard for Category 1 in terms of widespread use. It doesn't have all of the evidence basis yet, but it's on the way. And we want to make sure that we capture those within the CPT code set. It is one of the most visible areas of change. For what you are using, the standard, when a Category 3 code is approved, the standard is for that to be used for 5 years. Now, after that 5 years, there is an option. People can petition to say, hey, we're still using this technology. We're still gaining that evidence and that traction. We'd like to have that code extended for a little bit longer. So there are some codes. It is possible for them to be around for more than 5 years. There is also an option when they meet that it's been used enough, we actually have the evidence basis, that they may convert to Category 1. And when that happens, there will actually be a new code number that is created for them. You'll know Category 3s because, again, the code description, the code structure, 5 alphanumeric, last digit is a letter T, as in Tom. That will tell you it is a Category 3 code. They are ordered in the book in the order in which they are approved. So they are not subsegmented by body system, body site. It really is the order in which they come in. So that numbering scheme will be a little bit different. Okay. And this is one of the reasons I would say to make sure that when you're using the CPT code set, you want to make sure you're using the most current one. We did some analysis, there were some areas that where CPT was not required. They were using a code set from 2011, and they actually had to jump forward about 7 years. I said, if you use your 2011 code set and you looked at it for the time they were moving up to, about 75% of the codes in that section you would miss. And they are used here, and they're not used not just for tracking, they're also used for reimbursement as well. So again, if your applications take you into working with payers and payer sets, you want to make sure you have the most current version. Proprietary lab analysis codes, these are for specific labs and manufacturers to uniquely identify a test. It's a small subset. The structure, your code structure, again, it's going to be 5 spots, but it's going to be 4 alphanumerics, the letter U at the end. It's one of the few places where you will see a proprietary name or proprietary vendor's name or a lab or a manufacturer's name within the code set. We typically don't have them specifically. This was in response to specific government legislation to increase access to certain laboratory tests and procedures, and it was actually a construct created in about 2014 to accommodate those. This is constant innovation. These codes are updated on a quarterly basis, so this data set moves pretty fast. If you're working anywhere within the pathology or laboratory sections, you want to make sure that you keep track and don't be surprised if you see a couple of these codes. If that code exists, CPT reporting rules does say that that code needs to be reported even over and above a standard Category 1 code. So just from your hierarchy, the most specific code is what will rule the day, and that applies to PLAs as well. Another subsection here is multi-analyte assays with algorithmic analyses. Again, we'll give you the slides so you don't have to worry about all the algorithms. But there are specific types of algorithms. Again, another area where you have specific labs and manufacturers that this is unique to. Your structure, your code structure will be, again, 5 alphanumerics. Last letter is letter M, as in Mark. Will give you your MAAA codes. And there are some terms that, without additional espresso, I won't even attempt to speak, but they are here. Okay. Here's your summary slide. For CPT codes and categories, the upshots, so the different categories, Category 1 through 3, primary lab analyses, MAAA codes, the type, the use, the code structure you will see, and general notes on use. So if nothing else, you want to make sure you keep this on a fairly short leash when you're working with CPT codes. It is not all of the rules, but it will give you the highlights to get you guided in the right direction. In terms of the distribution of these codes within the 2025 file, here's a visual schematic. Section numbers and their sequences are here, but just remember these codes will change frequently. Some of the Category 1s are only updated once a year. Some of the category 3s are updated 2, 3 again. For PLAs, it's updated even 4 times a year. So this is something you definitely want to keep track of. But that'll give you general ranges. Obviously, as new codes come online, sometimes those ranges expand a little bit. But you'll generally see what you have listed here in terms of your category 1s, path and lab and medicine codes. Okay. Descriptor types. So as I indicated, you're going to see a couple of different types of descriptors, and words do matter. So the few things I would note here is that your long descriptor on the left-hand side, this is from the musculoskeletal area for a capsular contracture release. That descriptor is actually an official descriptor that has been approved by the CPT editorial panel. What I would recommend, but there are also translations, again, based on purpose. So you will see that same code number. If it's for a clinician descriptor, you may see a couple of different variants of that, because it says, how might a physician be looking at this information? And there may be a couple of different phrases or terms or approaches that are used, so it attempts to capture all of them. If it's a consumer-friendly descriptor, so it's used in a patient portal, it's going to be phrased a little bit differently. So you'll have a number of different ways that that code will be expressed. Things I will highlight: the long descriptor on the left-hand side is official. And I will name that because I know there are sometimes people will say, well, if you just have the code and maybe you don't have room for that descriptor, you can just change a couple words in the descriptor, right? I would highly caution against you do not do that. One, you may be changing the meaning or intent. And two, if you do that, there may be another code out there that represents the modification you just made. And CPT does always have an option to report an unlisted code. So I would say rather than risk misinterpreting or changing the meaning of the data, take it for what it is, rather than trying to change the words, because that may definitely change the meaning. For the clinician descriptors, note, because there may be more than one way to describe something. When you look at that structure, you may see a many-to-one structure if you are using clinician descriptors. So you may see one code, 2, 3, or more descriptors, depending on how extensive that long descriptor is. So that's the short version on descriptors, but you will see more than one type, and that's the reason why. CPT modifiers is a third construct. Now, these are codes that are used against their 2 digits, and they're designed to address care complexity or variation on an individual basis. So this is where a service or a procedure performed has been altered by some specific circumstance, but the base definition of the procedure has not changed. Okay. Many of these can also be response to payment policies. If something is in some of the standard code sets, it's listed here. Or for payer policies, let's say if you have 2 surgeons working together on a procedure, or you have multiple procedures going on in the same operative session, that's a way of identifying that. Let's see if we got some good examples here on the next slide. So the structure of modifier codes, it is 2 alphanumeric digits. More than one modifier may be applied to a CPT code. So let's say a patient's in the OR, they're having their knee replaced today, and they're also having some work done on that Achilles tendon. You may have more than one code, and one of them will probably have an indicator to indicate there's multiple procedures. And that is important for the payers to see, because it says, no, the patient did not go in and out of the OR 2 times, but there was more than was done. With the work that you're doing, what you will want to note is that for a given CPT code, if there's a modifier, don't be surprised or don't see it as an error if you see more than one modifier code applied, because that is talking a lot about what happened in that procedure. Another example might be increased procedural services. Say patients going in, they're getting their thyroid removed. It's a pretty standard procedure, but guess what? That particular patient had some very unusual anatomy, and the anesthesiologist had to do a lot more work to make sure that that patient was appropriately anesthetized, monitored, everything else. You'll see a code for anesthesia, and you might see a 22 set to it. And that's their indication that we had to do a little more work with this patient than maybe we bargained for. And it's more than what you would normally see. We still got it done, but we had to do a little bit of extra work. So these are only some of the ones that you'll see, and there's a whole list of modifiers, but these are some of the more common ones that we'll see. Synchronous telemedicine, number 95. There are a number of types of services now that can be done both in person in the office as well as with AV technology now. And so from a payer perspective, it's important to know this was applied using synchronous audio-visual technology. And for some of these codes, you will see a 95 modifier placed there. There are some special groups of modifiers. Physical status used with anesthesiology codes in particular. It's 2 alphanumeric. Again, the structure you'll look for is the letter P and a digit from 1 to 6. That talks about the particular morbidity characteristics of that patient, and it relates to the work that the anesthesiologist has to do for that particular procedure. Category 2 modifiers, those are those quality modifiers, those quality codes. They have their own modifiers. Again, structure 2, alphanumeric, a digit in the front, and the letter P. So you might find a modifier there for maybe a patient meets all of the criteria for this measure to be applied, but that intervention wasn't applied. Why? Patient declined it. Okay, so it kind of takes it out of it, makes sure that people understand if there's a reason that that particular intervention wasn't applied, that it accounts for that. So you're going to see a couple of modifier categories that are going to be unique depending on the code structures that you're working from. Now, in addition to the structures that we talked about here, as I indicated, there's a lot of additional coding guidelines and instructions. We won't go into them here, but it does help to improve standardization. Again, this is a uniform language. So the idea is that if we're all following the same sets of codes and guidelines, when you look regardless of the care setting where that patient's receiving care, if you're working on longitudinal analyses, connecting information across payers, providers, researchers, just know that there are sets of rules that apply, and there are rules in cascades. So we've got additional information around beyond the scope of this presentation that talks about them. So there are some overall CPT reporting guidelines that would need to be followed, and then there are certain guidelines for certain sections, subsections, and even codes and code groups. And if someone is reporting them, just realize they may be using rules at one or more levels that determine their selection. And we have educational products and things like CPT Assistant to provide additional guidance beyond just the codes and numbers, but how they're used. I wanted to raise it here just so you're aware with the data you see. You might say, why are there some variations? It looks like it should be the same. There may be some specific coding rules that were applied when the data was originally generated that you may not see in some of the data that you're working with. And in terms of those instructions and guidelines, this is where the interactions with payers come into play, because for CPT, we have reporting guidelines. And those codes and descriptors, are a HIPAA standard. They are key for correct reporting. They are required for claims. Now, when you start talking about claims, here is the interaction with insurance companies and payers. Because some of those insurance companies and payers, when we talk about CPT and getting paid, there's 3 different steps that everyone knows about in terms of CPT content. It's a step on the path to reimbursement. The first step is, can you report it? That's where identification of a CPT code comes into play. The next 2 are, now that you've reported it, is it covered by your insurance plan? And then, if it's covered, what does it pay? What's the reimbursement? Steps 2 and 3 are the purview of the third-party payers. So we might have rules, but when you go talk to Blue Cross, Aetna, they may have additional reporting guidelines that come into play. And so these will start to come in for coverage, obviously with a payer. They determine how they want to design their benefit plan as to whether or not they will cover something. And then in reimbursement, obviously, that is something that the payers will also determine. So while there's rules of reporting within CPT, when you start going into the payer realms, they may add additional rules depending on how they want to run their business. So there's multiple levels there. And so just to be aware of that, again, that they may have additional billing requirements even beyond CPT. Hopefully they're in line, and usually they are, but they may have additional ones that they layer on because of how they want to design their benefits for their constituents, which will have an impact on the data that you're working to connect. Okay. I'll take a couple last minutes on the set editorial panel process. And don't worry, there's a lot on this slide, but some of the key takeaways is to remember that the editorial panel process is a few key items. Evidence-based, it's a clinically valid, criteria-based, all of these chevrons you see at the top. This is an open and transparent process. And it's clinically oriented, evidence-based, and believe me, rigorous. Like I said, you've never seen people debate the position of a semicolon like you've seen when you have 21 physicians around the table and hundreds around in the room talking about it as well. The decision-making criteria for determining whether a new CPT code is created or changed, that is publicly available, by the way. But you can imagine those 11,000 plus codes take a little bit of maintenance work. And so the key to all of this is a CPT editorial panel. These are 21 physicians that are appointed by the AMA Board of Trustees. They are the primary, and they are the ones who are responsible for creating, revising, and updating codes, descriptors, and applicable guidelines. So those are the official segments for appropriate CPT reporting. And when those panel members come up, they come from various medical specialties in the industry, but they don't advocate for their specialty once they're appointed to the panel. They focus on the structure and the integrity of CPT overall. Now, they get a lot of help from the folks around the circle. So with those 21, we have our CPT Advisory Committee. That's pretty much all of the different medical specialty societies that are represented. That's over 100 societies, as well as people from our non-physician areas, so your nurses, your ophthalmologists, your PTs, your OTs. Everybody gets a chance to come in and opine and work on creation of these codes. We've got representation from various organizations such as payers, so folks from Blue Cross, America's Health Insurance Plans, the American Hospital Association has seats. We also have input and review from organizations like CMS, as well as now the FDA and the CDC. So we all kind of work together to ensure that we've got some of this connectivity and helping increase interoperability and transfer across these different organizations. But there's a number of different advisors, committees, subgroups in certain areas like Path and Lab, who can speak those terms a lot more fluently than I can, and certain subgroups, and also representation from, or the opportunity for industry manufacturers and laboratory folks to give their expertise as well. That's generally hundreds of participants. This group gets together 3 times a year to meet and review code change applications. Our most recent meeting was just last week. So they will be meeting again in February. And it is an open process, by the way. If you've ever wanted to see a CPT editorial panel meeting in person, you can do that. Its information is available, and it's quite an experience actually to see these codes come together and be created. But a lot of work goes into creating these. The code change application process, in terms of how it's done, won't go into a lot of details, but you've got 5 key steps. Submission of an application for a code change application. This can be a new code. You can decide something needs to be revised. Perhaps medical practice has changed. We need to revise the codes to keep them current. And anyone can submit a code change application. It's not limited where it only has to be a physician or someone. We've gotten code applications from all different segments. Those applications, when they come in, they're reviewed by our panel members and advisors to give input. There's comments from those advisors and IPs, what are called interested parties, to be able to give input. They give input back to the applicants. And the applicants can take that information, and up to a certain point, they can make adjustments. And then at the panel meeting, those applications, those tabs, are discussed. So they've been reviewed by the editorial panel. They've had an opportunity to be reviewed by all of the different specialties in medicine. Anyone who, say, is an interested party, perhaps they have similar technology in this space, they would like to make a comment, they have the opportunity to do that. And then at the panel meeting, the panel will decide with all of that whether or not to accept, reject the code, keep working on it at that meeting, or have it come back at a subsequent meeting if the application needs more work. Now, until the application is actually presented at the panel meeting, the applicant does have the opportunity, if they say, well, I'm getting some feedback, I'm not quite sure if this is ready to go, I'd like to withdraw that application and work on it a little bit more. That's fine. There's no, that's a hold harmless procedure. You can certainly do that if you see that you need to do a little bit more work in refining things. All of the actions of the editorial panel are posted on our public website about 30 days following the meeting. So it's a subset, but if you're ever interested in new codes that come through or what's happened with that particular application, we do have some publicly posted results that are made available to the general public. And this is pretty flexible, nimble, and transparent panel. So even though we only meet 3 times a year, there are many times where we actually, those meetings, by the way, they're hybrid. Again, they're open to the public. The summary of actions is posted. And there have been times where we've sped up that process to make sure that we continue to sort of report and reflect medical innovation that happens. Innovation doesn't just happen 3 times a year. There's a lot of other stuff that happens. The standardization supports the monitoring and measuring quality and future research, particularly in areas we're taking a look at the next generations of innovations. AI is huge right now, and that's actually one of the areas where the code set's growing pretty exponentially, along with digital health. And we do, based on medicine for a U.S. population, and sometimes there are things that happen where we have to be nimble and flexible and responsive, and COVID was certainly an example of that. So I won't go into all the details, but I will say over a 2-year period, CPT did rapidly respond to that COVID pandemic. When you think about it, we have codes for not only the tests, the lab codes, but also for supplies that were needed, all the vaccine codes. Now, this is a special section. If you are doing longitudinal studies, the need for, and this is where payers intersect, because we realized that in doing this, there were specific requirements that we needed to meet to have more granular reporting, not only on those vaccine products, but also on the administration of those products. And they went down to not only which vaccine is it, but which dose and which dose sequence is it. For a small time in the CPT code set, you will see certain codes. They are category 1s. They're going to be 5 alphanumeric. The last digit is an A. Those were specific codes that were created. We created 47 of them. Rather than meeting 3 times a year, we basically had that panel meeting monthly to get those out. But you will see a unique category code structure that represents those very granular COVID administration codes. I say it's limited because after 2024, we no longer had a need for reporting at that granular level, and so we took those codes off. So when you think about the history of CPT, if you're doing any work in that area, that's why it's important to keep track of not only the most current one, but look to see, is there something else that's happened in the past that might be impacting the type of coding that you'll have to be doing. But that's going to be a special category, because if you look today, you wouldn't see it. And if you're doing longitudinal studies and you didn't see previous versions, you'd miss it. A couple of other code examples, I won't go into detail here, but some examples in digital health and AI. A lot of the remote monitoring things done outside of the bricks and mortar environment are where a lot of the editorial panel has been putting their focus in the last couple of years. Some of the key ones I'll put here, obviously your online digital evaluations, digital visits and e-visits, self-monitor blood pressure reporting, remote retinal imaging, remote physiologic and therapeutic monitoring used in a number of different areas. You will also see a new appendix effective January 2022 of an AI taxonomy for medical services and procedures. This is not something we've had before, but as that area of the code set has started to grow, we've also started to give some additional guidance for classifying the various artificial intelligence, augmented intelligence systems and applications that are coming through. And that's just a little bit more on the taxonomy that's available actually on your website. And so we're making a lot of progress along that front, and we continue to evolve there. So in summary, when you're looking at the CPT code set, think of it as an interoperable language. It's used not only generated by the physicians and your health professionals, but used by a number of different constituencies across the healthcare ecosystem, both for primary use as well as secondary use. Insurance companies, all the different facilities, regulators, standards development, researchers, hospitals, et cetera. It is comprehensive guidance designed to be. Linked to quantitative data, again, that resource utilization, if you're doing any work around reimbursement, outcome studies, economic studies, you will come across this. So be aware of that. And it is physician-led government. So this is not designed to be digital native. It is designed to incorporate the thinking process of the clinician into it. And they do drive the evolution of the code set. Now, for some of you, that may mean you have a few more exceptions to write in some of your coding than you might be used to. But in some ways, thank goodness, medicine is not simply a cookie cutter process without regards to individual patient characteristics. So it is based on clinical evidence, and it helps to keep pace with medicine. Now I'm going to turn it over to Dennis in a little bit. There's a lot of additional online CPT resources and education. Again, may not all be directly applicable to what you're using, but just know that you've seen a subset of this today. And there's quite a bit more to be explored if you have interest that's actually on the CPT website. Now with that, I'm going to turn it over to Dennis, who's going to talk a little bit about the standard file so you can get a better sense of how this is represented in what you're going to see. Dennis?
Thank you very much. Thank you, everyone, for coming to hear about what we're working on, what we do at the AMA. I'm Dennis Casbon. I'm on the product team, and we are tasked with taking all that complexity and great reflection of the practice of medicine in the code set and trying to turn that into data products that are usable throughout the industry in all of the electronic systems that you see today. It's like taking 10 pounds of CPT content and trying to stuff it in a 2-pound sack, and that's definitely how it feels when we look at the situation with the pages that Meryl mentioned on the HL7 website, where we're trying to make sure that CPT is accurately reflected in the normative structures in different standards areas. To jump into the standard file, so this is really the way that we communicate the code set out into all of those electronic systems throughout the ecosystem. And it's very challenging to get all of that context into just a data file. And so what you'll see is that we try to distill the most important information and get it into the files, communicate it accurately, and so it can be loaded efficiently and represented accurately throughout the different systems. And to that end, the standard data file, if you do work with it, then you would see all the detail here. If you work with kind of the outputs, we're hoping that those particular elements are easy enough to incorporate in the different systems. You see the code and all 6 descriptor types. There's a separate modifier file with all the details there, all the details that surround the PLA code, since that is more complex than some of the other CPT codes. We have started putting in an effective date. It's a current descriptor effective date, and this is where CPT is very similar to other terminologies in some ways and very different in other ways. And the descriptor is one of those places where there's so much contextual background that's baked into the descriptor, and that's why Leslie was saying that it's very important to focus on the words that are in that specific descriptor. And then, if that descriptor changes, we want to make sure that you're using the most up-to-date scope for that code. So what's key there is the scope may change based on the current practice of medicine, and that would impact reimbursement. And so if you are trying to meet the needs of a code as it was written 2 years ago, but it has changed, then you may be denied when the scope has changed in the current version. So things like that, we're trying to make sure that there's visibility into when a code changes, how it changes. And then you can see more about how the standard file is laid out on the AMA Intelligent Platform resource there. Okay, so I'm not going to go into this, but like Leslie said, the code set is really dynamic and it changes frequently. The good thing is that those category 1 codes that are kind of the bedrock of coding don't change as frequently. But because there are other services that are very dynamic, we have multiple different update schedules through the year. And these different updates are posted to the website, but we're also working to capture those updates accurately in the code set itself in the CPT standard data file. So that way you don't have to worry about finding updates in 20 different places. We typically release the data file on an annual basis plus 4 quarterly updates. And those releases are set at least a few months in advance and of the code changes being effective. So you do have time to incorporate those code changes before they need to be in a particular system. Some notable changes in the past couple of years. We did collapse all of the different files. As we looked at how people were using the code set in the past and how that use is changing. You saw Merrill's exhaustive list of use cases that kind of scratched the surface. We do want to make sure that the code set is more accessible and usable in those different use cases. And so one of the things that we were hearing was that the old standard of having everything broken out and easily loadable in specific discrete files was no longer required, so we did collapse those and we update that more frequently. We have a data dictionary. We have the consumer-friendly descriptors in Spanish. That's included in this file. CPT has been translated into other languages for specific country use. Those other translations are not included here, but this was our first US-based CPT standard data file translation, and we're certainly open to translating into other languages as needed. And then that current descriptor effective date. In the release next week, as an example of how the collaboration with HL7 has impacted the outputs, we're adding a deleted code data file, and so that really just reflects the need to say, the CPT code set changes a lot, and when codes are deleted, it's not always reflected in the standard data file because that is the current view of what codes are in practice. But that doesn't mean that knowing that a code has existed in the past isn't important, and so that's one of the ways that we're updating the data file to represent the needs of developers in the community. Transitioning to say, we also have heard several requests to understand the code set more thoroughly before it's really a licensable event. So before somebody has a full-blown EMR that they're licensing, that they're using in several hospitals, they're going to build it first. And so we created the CPT Developer Program. It's really a way to be more familiar with the data aspects of CPT. We want to understand how to translate that rich contextual guidance that goes into the creation into the use cases today. And so the developer program has a few different elements. It's free to sign up. We have different events and whatnot, but the first aspect that you'll see is that there is a development license for early stage companies or companies that that don't use CPT in production today. We'd have educational opportunities, webinars, and other newsletters and things like that. And then engagement opportunities, we have dev chats and other types of events like that. This is all built on the AMA Intelligent Platform. So it's really just the digital front door for access to CPT content, licensing, learning about CPT. Things that we have on here are product catalog information. We have our dev portal. We have various APIs. We're not a software shop. You saw that huge list of ways that we interact with HL7 and other organizations. We are not the ones developing all the software, and so we're slowly getting into the API and FHIR business, but we do have some capabilities on that end. We have the dev program resources, other documentation throughout, and then FAQs and support. For the dev license itself, royalty-free access to the full CPT code set, and we just ask that people share about a bit about their use case. They need to renew every year with an update on how it's going, and it's for non-production use. So when we look at how people are using that, we have a lot of different use cases that, these aren't just nearly as descriptive as the editorial panel would perform, but just at a high level, people use CPT for a lot of these different areas, and that's what we see in the developer program. Analytics, improving information, just exploring new use cases. Sometimes there's a sense that, well, I'm building something for healthcare and I'm not sure how CPT will be used in it, but I want to understand the structure and the depth, and then work on, does it fit into my software? Claims management, of course, all the rev cycle aspects, EMR and price transparency. Here's just a quick breakdown of the volumes of people that we see in each bucket. Claim management, notably and understandably, is the highest. Improving information is second, and that really speaks to it's a complex code system that is difficult to communicate to an end user at times. And so there's a lot of development activity around making sure that they can accurately reflect the CPT codes and descriptors and put it in a way that is usable in end systems. And so that's no surprise as well. Seeing this helps us understand too, what do we need to do to the code set itself, to the data format of the code set, to accurately communicate all this information all the way down. Lots of educational opportunities and resources. You can go to the website and explore there. But we have several different areas in the AMA. It's not just CPT. And so because we're a physician's ally, then everything we do is built around how do we reduce burden, how do we make the practice of medicine more effective, leading to better outcomes. And so there are a lot of related types of thought leadership that the AMA produces that are relevant to a more technical focused community. And we share those resources there. The developer program, dev chats have been a lot of fun. We've had a lot of great speakers. Chuck Jaffe was a speaker at one last year talking about the collaboration agreement. Recent speakers have been from Mayo Clinic, Microsoft for Startups, Rock Health. And so it's always a great perspective on what are different people in the industry seeing and how does that relate to innovation in healthcare. Yeah, it's not too formal. It's usually a good discussion. So happy to have you at those. And then a couple of other relevant opportunities here to participate. There's a Physician Innovation Network. It's kind of like a Match.com for physicians and really anyone in healthcare that are trying to develop new ideas and work on innovative items. It's a community where there are discussions posted, and there are also opportunities that you can post, that you can look at around just weighing in on a startup that a physician has begun. You can get feedback on your particular developments and whatnot. So it's a good community resource. And then in Full Health, so the AMA is very focused on making sure that equitable care is promoted throughout software and in different areas in healthcare. And so this is a special carve out where it's more deep dives on how equity looks in healthcare, state today, how to improve it. So lots of great resources through that website. Okay, for the developer program, if you'd like to get involved, you can sign up. join us at Dev Chats. Really passive push here for engagement, but there are different ways that you can participate with us. And we'd love to hear your feedback, love to hear what you're working on, and that's that. So with a few minutes left, I'll just thank Dan, thank HL7 for having us. Thank you for attending the session. We'll post this, and so if other people on your teams or that you know need a deep dive and a really good basis for understanding CPT, you can have that when ready. We'll take any questions if there are any, and thank you. Yes.
I'm trying to understand, is there any specific structure to billable codes that differentiate from what we consider non-billable codes?
Structure, so the question is there structure to billable versus non-billable codes?
In terms of billable versus non-billable, thanks, yeah. In terms of billable versus non-billable, probably the only advice I could give you would be that pretty much all of the codes that you see, perhaps with the exception of Category 2 codes, because Category 2 is a quality measurement. Remember, that's 5 alphanumeric, last digits an F. Those will be for performance measurement programs. Reimbursement isn't necessarily tied to them, but Category 1, Category 3, PLA, MAAAs to a little lesser extent, all of the other categories can be used on a claim. Now, whether or not they are covered and paid is up to the payer, but all those other groups are fair game for billable codes.
Second question, when you use the phrase an episode of care, is that consistently defined across all codes, or is it kind of context dependent based on the code?
Good question, and I would say, I think when it comes to episode of care, in the years I've seen, I have yet to see one consistent definition of episode of care. If it exists, it's like looking for that magic repository of any and all outpatient claims data in one place. I've been looking for that for 30 years, because if I'd found it, I'd be retired and living on a nice little island somewhere right now. But no, I have not seen a consistent set, and I'm sure, a lot of it is going to be context dependent, depending on who you're talking to and what the purpose is. So it'd be great to see it. I have yet to see it myself.
One additional thought there. One of the differences between CPT and other code systems is that there is a relationship in a CPT code where it could be several different aspects in the episode. So the procedure may be on the head or neck or shoulder. So there are kind of options in that CPT descriptor. And so when you're thinking about an episode, the code is meant to describe the approach to the service. And so sometimes when you're thinking about, could that be multiple things or one thing? And that's one of those areas where it's challenging for us, but definitely worthy of the attempt to describe how that complexity shows up in a data format. Graham?
So first of all, thank you for being here and doing this. Thank you for working with us, and in particular making the master codes available of that. You talked about opening up, and so I have to ask, where in your roadmap is providing services or access for patients who receive records that contain CPT codes that they need to, I guess, understand where is that on the AMA roadmap?
So the question is, where on the roadmap is giving access to patients for CPT-related information in their record? Is that right? So we do this in a few different ways. There's not like a code lookup for patients today, but we do things like when an EMR or similar software has a patient-facing portal or service. We don't charge an additional licensing fee for those patient-facing aspects. And then there are a number of other things that we do to make price transparency uses of CPT low or no cost. So there are several different ways where we try to enable specific patient-facing applications of CPT. So it's not like a defined roadmap item, but we can certainly talk about, what options there are and if there's something that we can do to support that.
So if you two particular things.
Yep.
It'd be good to provide a service to patient frame applications to do code lookup validation.
Okay.
And it would be good to give them a clear license path for free use of CPT for that purpose.
Okay, got it. So the comment is a lookup validation service for patient-facing applications, royalty-free. Yep. Yep, that makes sense. Okay, yeah, we'll take that back. Thank you. Anything else? Oh, Meryl?
And I know we're out of time. The only other thing I would mention is maybe before you came in, Dennis and Leslie both went into some detail about the consumer-friendly descriptors. So we may want to think about that as part of the solution, because we're not expecting patients to necessarily understand, or any of us for that matter, the long descriptor, which is complex and more technical. So we would be happy to think about that as well.
On that subject, I think more than just patients would enjoy a short, succinct display. Yeah. But
So-
thank you. I'm sorry we weren't here earlier, and thank you.
No, this is good.
Yeah, absolutely. Just a quick note on that. So there is the full descriptor, but within the CPT files and hopefully within the data files as well, there are truncated versions. There's the full descriptor, there's a medium and a short, designed for use within computerized systems where you don't have the room. And you've seen it. I can find some pathology and genetics code descriptors. The length will make your head spin. But there are medium and short descriptors, as well as descriptors designed specifically for consumers, patient-facing portals. So to translate and adapt to a language that makes sense for a non-physician to understand, and then also clinicians. So there's a number of different kind of translations on that main code depending on the use case.
I do understand the readable short version is the request there. That's, yeah, yep. User needs and requirements, definitely. Okay. Any other questions to wrap up? All right. Thank you very much, everyone, and safe trip home.